Good afternoon and welcome to Baptist Health International's quarterly medical lecture. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health, and a moderator for today's lecture. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America and the Caribbean and to all who are with us today. This afternoon, I have the distinct pleasure of introducing Dr. Lunan Ji, urologist at Baptist Health, South Florida. His presentation will be an introduction to stress urinary incontinence and update on current treatment options. Dr. Ji is a urologist specializing in general reconstructive and female urology and also experienced in robotic and minimally invasive surgery. Dr. Ji sees patients for a variety of urological conditions, including voiding dysfunctions, incontinence, prostate and urinary disorders, pelvic organ prolapse, kidney stones, erectile dysfunctions, among many other conditions. Dr. Ji received his medical training at the University of Buffalo School of Medicine and Biomedical Sciences in Buffalo, New York. He completed a residency in urology in the University of Miami and Miami, Florida. He then completed a fellowship in female pelvic medicine, reconstructive urology, and voiding dysfunction at Columbia University Medical Center in New York. Prior to attending medical school, Dr. Ji earned a bachelor's degree in biomedical engineering from Columbia University. He worked as a biotech analyst, and through his experience, he learned to stay at the forefront of medicine and to use the latest techniques and treatments to better the lives of his patients. Dr. Ji is a member of the American Urological Association and the Alpha Omega Alpha Honor Society. During his residency, he was awarded a scholarship to travel to Vietnam to perform reconstructive urological surgeries. Dr. Ji has been a presenter at various local and national conferences. He is fluent in both English and Mandarin. Please, let's give a warm welcome to Dr. Lunan Ji. Dr. Ji, what a pleasure having you today.
Well, thank you for that kind introduction. So, should I share my screen? Okay.
Yes, go ahead and share it.
Okay, so. Right. Are you guys able to see my the presentation? So
yes, we can.
Well, thank you everyone for joining me this afternoon. So it's in that kind introduction from Dr. Hakim, we'll be talking about the management of stress urinary incontinence, and let's talk about some of the objectives of our talk from today. We'll talk about, so we want to define what stress urinary incontinence is, as well as how to differentiate it from other types of incontinence. We'll both review the anatomy as well as the pathophysiology of stress urinary incontinence, and that's abbreviated as SUI. So I'll probably say stress urinary incontinence about 1 million times if I don't use that abbreviation. So we'll also review how to evaluate patients with SUI and review both the non-surgical as well as the surgical treatment options for stress urinary incontinence. So let's start with some definitions. So what is incontinence, in general? So incontinence is the symptomatic complaint of the involuntary loss of urine. So when a patient comes to you and they complain of incontinence, they might not be able to tell you exactly what exactly the type of incontinence is. So we do need to elicit some history from that patient. We want to figure out what's the cause of the incontinence. How severe are the symptoms? How long has the patient had the symptoms? Is it something they maybe just had a urinary tract infection, something that's coming in for a few days, or is it something they've had for months and years? How frequently are they leaking urine? And most importantly, how much, how is this impacting their quality of life? So what are some of the different types of incontinence? So, we can have, something like overflow incontinence, one type of incontinence. That's when somebody is actually in urinary retention. When they come in, they tell you they're unable to urinate, they feel their bladder is full, and their bladder is so full, it can actually overflow and leak out. So other type of incontinence, someone may not realize when they're leaking. It's called insensible incontinence. So when someone is complaining, they don't realize when they're even leaking urine. So they may have poor bladder sensation or some other issues going on. Or a patient may just continuously leak urine all the time. We'll often see this in our neurogenic patients with some type of spinal cord injury. Although you usually see more urinary retention in those patients, they can have, for instance, an open bladder neck or open sphincter, and they may just continuously leak urine. Now, more onto, so other types of incontinence include functional incontinence. So the patient may be old and they may be bed bound. They're unable to get out of bed in time to go to the bathroom in time. So that's more of a functional status. Or someone may have recently had orthopedic surgery and they can't ambulate to the bathroom quickly enough. So, that would be, maybe there's nothing wrong with the urologic organs, but they may just need some functional assistance to deal with their incontinence. So then we have stress urinary incontinence. So stress urinary incontinence is really the complaint of involuntary leakage of urine with exertion. Anything that that increases your intra-abdominal pressure, that's sneezing, coughing, exercising. We need to really, and the symptoms are usually better at night. So that's kind of one of the key distinguishing factors compared to the next type of incontinence I want to talk about, which is urge urinary incontinence. Because usually at night, when the patient's lying down, you don't have the gravity working against it. So the odds that something could leak out tend to be a little less. So there's also urge urinary incontinence. So this is more like a bladder spasm. So this is the complaint of involuntary leakage of urine that's immediately preceded by a sense of urgency. And, oftentimes patient complains of frequency, urgency, and, urinating at night, waking up multiple times, or they're leaking urine at night. So sometimes something you don't usually see in stress urinary incontinence. What's actually more common than both urge and stress urinary incontinence, it's actually a mixture of both urge and stress urinary incontinence. So, as much as we like to define these diseases as separate diseases, patients often present to us with a more complex picture. So patients may have both stress incontinence as well as urge incontinence. You have to really distinguish, tease out which one is a more predominating factor. And, you need to treat both, because the treatments for the different types of incontinence could be quite different. For urge urinary incontinence, usually revolves, behavior modification, avoiding bladder irritants, or using medications that essentially relax the bladder. There are also advanced treatments for urge incontinence, like Botox injections in the bladder, or a nerve stimulator that restores some of that calming signal. Versus in stress incontinence, usually it's about restoring some of the anatomy, whether that's through pelvic floor exercises or surgery to kind of strengthen the pelvic structures. So very important to distinguish the different types of incontinence. So about stress urinary incontinence, it can have quite a significant, all types of incontinence can have a very significant and negative impact on the quality of life. But stress urinary incontinence in particular can cause quite a significant amount of leakage, can affect sexual function, the patient's psychological well-being, all other aspects of quality of life can really become quite predominant. And it's quite prevalent. It's definitely something that's much, much more common in women than in men. And different population studies have found it to be as prevalent from 25 to 50% of women have some type of stress urinary incontinence. And here in the United States, it's estimated that we spend about $12 billion on incontinence products and treatments for stress urinary incontinence. So it has a big economic impact as well. And for, lifetime risk of needing surgery for stress incontinence in women is up to, about 13 or 14%. So, it does carry a significant amount of morbidity as well. So, the 3 time periods we tend to see onset of stress urinary incontinence. One is in younger women, usually immediately after delivering, particularly after vaginal delivery. These tend to be quite transient, and most of them do improve on their own over time without requiring surgical intervention. We also see in the perimenopausal period where there's a decrease in estrogen to the vaginal support tissue. You see some weakening, but you see vaginal atrophy and some weakening of the tissues there over that time period. And also you see in later years where you tend to see more, it's called intrinsic sphincter deficiency. I'll go over that a little more detail when we talk about the anatomy, versus in the perimenopausal years, you tend to see more, it's called urethra hypermobility. And I'll talk to you about how we can, establish that and what to look for on physical examination. So what are some of the risk factors for developing stress urinary incontinence? Obviously age, older age is a big risk factor. Pregnancy is one as well, as we talked about. Prior hysterectomy also puts you at higher risk for about 8.5% of women after a hysterectomy develop stress urinary incontinence afterwards. And the number of times a woman has given birth, as well as the number of vaginal deliveries, is also a risk factor. Caucasian race is also a risk factor. Obesity and being overweight puts additional weight and stress on the pelvic organ structures and puts women at higher risk for both stress urinary incontinence as well as pelvic organ prolapse. Smoking can significantly weaken the tissue and the ability to regenerate tissue. So that's definitely a risk factor as well. And for men, as I mentioned, that stress urinary incontinence is not very common in men, but it does happen usually after some type of prostate surgery. It's fairly rare after surgery for bladder outlet procedure, for instance, as a TURP for benign enlarged prostate, but can be quite common after treatment for prostate cancer, such as a radical prostatectomy or prior pelvic radiation. So what are the anatomies? So we're going to focus, because stress urinary incontinence predominantly affects women, we're going to focus more on the female anatomy. And why is that? That it predominantly affects women. Partly, is the length of the female urethra. It's approximately about 3 to 5 centimeters. That compared to the average length of the male urethra is about 18 to 20 centimeters. So it's quite a dramatic difference. So as you learn back in your physics class, you have a tube that the longer the tube, the greater the resistance. In addition, men have a prostate that women do not have that sits right in front of the bladder, and that increases the resistance as well. So, men, unless you had some prostate surgery or radiation before, tend not to develop SUI. It's much more common in women. So, the female urethra can generally be divided into the proximal half, where it's closer to the bladder and closer to the bladder neck. That's usually innervated by autonomic nerves, tend to be out of voluntary control, versus the distal half where the urethral sphincter, this is the voluntary sphincter we think of. It's both under both active, kind of autonomic as well as, skeletal muscle control. So when you tighten, you want to stop urinating, it's usually the external sphincter we're talking about there. So, and there's certain attachments to the female urethra that's important for providing the support. I won't go into too much details about it, such as a pubourethral, some of the different cardinal ligaments that that attach to the different areas. But these attachments can weaken over time, and that's that you lose some of that support around the urethra, and you see what's called urethral hypermobility. And that's when the support structures is kind of a dynamic support structure. So we think of the pelvic floor muscles, the puborectalis, pubococcygeus, the iliococcygeus muscles, they're providing kind of this support for the pelvic structures, and it provides what's really a dynamic support. So when we increase it's not a static fixture there. So when we increase our intra-abdominal pressure, the shape of the pelvic floor actually changes and provides a backstop, preventing our urethra from moving too much. And when we lose that, that back support, and we lose some of that dynamic support, we actually see what's called urethral hypermobility. So, when you do a physical exam on a patient, you have them cough, strain, push down. The urethra really normally, under normal circumstances, really should not move very much. But you'll see in a lot of these patients, they would have quite a dramatic movement in your urethra, and often accompanied by leakage of urine on exam. So what are some of the symptoms? We went over some of this already, with stress urinary incontinence, it's cough, leakage of urine with coughing, sneezing, when someone's getting out of a car, lifting something heavy, or even during sex. That could be quite embarrassing for patients and have a dramatic effect on their sex life and then other quality of life as well. Pretty much anything that increases the intra-abdominal pressure and that leads to urine, that's causes stress urinary incontinence. So this is something that I learned actually as a medical student, that in actual clinical practice we very rarely do, but it's a good illustration of the urethral hypermobility. I think it's called the cotton swab test. So you actually place a cotton swab into the patient's urethra, and you look at the change in angle when the patient's either valsalvas, when they kind of strain down, or they cough. And if that change in angle is greater than 30 degrees, that's considered a positive cotton swab test. Okay, so but generally you don't need to necessarily the invasiveness, the risk of introducing bacteria into the bladder to actually put the cotton swab test. Once you've seen a number of these, you can actually just repeat that test without the cotton swab and just observe the motion of the urethra. You're able to see that hypermobility. What you want to see is both the hypermobility as well as the leakage of urine. So if what's called a cough stress test. So that test may be negative when the patient is lying down, because you don't have, as I mentioned before, we don't have gravity working against you, that tends to pull the urine out to the floor. You can actually repeat the test again with the patient standing. What's also important is how full is the bladder. Maybe the patient just went to the bathroom 30 minutes before they came into the to your office and they have an empty bladder. Without a relatively full bladder, you're not likely to elicit a positive test. So one other possibility is you actually see urine leakage with a positive cough stress test, but you don't see a hypermobility in your urethra. So that tends to suggest what's called more intrinsic sphincter deficiency. It's what's called a fixed urethra. You tend to see this more in older women, and this tends to be more of a weakness in the sphincteric muscles. And there are certain tests you can do, such as urodynamics. They may have low urethra. The ability of the urethra to kind of coaptate, close in on itself, is weakened. So you may have actually leakage without that hypermobility. I will say you will see that hypermobility in the vast majority of people, but since certain patients, particularly older women, you may have what's called IST, the intrinsic sphincter deficiency. So keep that in mind when we start talking about some of the treatment options for SUI, because it does come into play a little different. Whether they have IST or primarily more of a hypermobility etiology to the so when you're evaluating a patient with stress urinary incontinence, you really want to do a good history and physical exam, as we just talked about. You want to get a urine analysis, make sure they don't have a concomitant urinary tract infection that may be contributing to symptoms. Again, very important to assess how much are the symptoms bothering the patient. You can obtain a voiding diary to see how often the patient is leaking. Something that's probably more done in clinical trials is called a pad test. You can actually even do a weighted pad test. And if you don't do the weighted pad test, which you can only really do in a clinical trial, the pad test may not necessarily be that accurate. So I'll have patients that come in and say, I have 5 pads, I change pads 5 times a day, I have 5 wet pads. But some patients may be changing when they just have a tiny bit of leakage, and you have other patients that the pad is completely soaked and they're only changing it twice a day. So very, very important to assess how wet those pads are when they are changed as well. Also checking a post-void residual. This can be done either by ultrasound using a special machine that uses ultrasound to measure that, or you can catheterize a patient after they void. So this may portend to other issues. They may have some neurologic issues, so either weak detrusor. So if they do have a high post-void residual, that may suggest some other problems in addition to just straightforward stress urinary incontinence, such as pelvic organ prolapse or some of the neurogenic issues that I mentioned already. You can consider a cystoscopy, which is looking inside the patient's bladder with a camera, or doing a special test called a urodynamic study. I don't usually do that on most patients that have straightforward stress urinary incontinence. And I'll go over a little bit which patients where that may be more important to obtain those studies. So what is a urodynamic study? So it's essentially I'd explain it to my patients. It's almost like an EKG for your bladder. A catheter, a special type of catheter with a pressure transducer is inserted into the bladder, and it measures, and the bladder is filled, and the patient's asked to both cough and void. It measures the voiding pressure, how strong the bladder contracts, whether the patient's able to fully empty their bladder, whether the patient leaks or not. And in a concomitant catheter is kind of equilibrize the pressure. This is inserted into the vagina or in the rectum in male patients as well. So, and it gives you a result that looks, like this. I won't go into too much detail. We can spend a whole hour just talking about how to interpret urodynamic studies. But like I said, I usually don't obtain this in the straightforward stress urinary incontinence patient. So when do you need to, maybe consider getting a urodynamic study or a cystoscopy? So if you're not able to see the stress urinary incontinence on physical exam, you have the patient stand up, you fill their bladder, they come in with a full bladder, they're complaining of leaking, every day at home, but you just can't reproduce it in the office. That may be a setting where you may want to consider some of these tests. If the patient has primarily urge predominant, they have mixed urinary incontinence, but it's primarily urge predominant, you may want to consider obtaining this. So if you do a surgery on somebody, you fix their stress incontinence, but you don't do anything for the urge incontinence, when the bladder contracts very strongly during an urge episode, no matter how good of a stress incontinence surgery you do, it's going to push right through that. The patient's still going to leak. They're still going to be leaking all the time. They're going to think their surgery didn't work. and hate you for that. So you want to, if there's someone has a really urge predominant, you really probably want to work on that first, get that under control before focusing on the stress side. So if someone has microscopic or gross hematuria, you want to make sure they don't have cancer or something like that in their bladder. Cystoscopy would be appropriate in that environment. If someone, something I mentioned before, the post-void residual, if that's high for whatever reason or not emptying their bladder well, you really want to make sure they don't have a neurologic issue. Or if the patient has high prolapse, which can also lead to high post-void residuals, a cystoscopy or urodynamic study may be appropriate in those settings as well as patients that are a little more complicated if they have recurrent disease after prior pelvic surgery as well. So basically, this is a study that was published in the New England Journal of Medicine. So basically, that just kind of justifies what I just talked about before, that in uncomplicated stress urinary incontinence patients, performing a urodynamic study doesn't really change the outcome. So I only really do it in select patients. So what are the treatment options for stress urinary incontinence? So, we can, if it's mild and not very bothersome to the patient, we can really consider observation. If it's something that only happens once a month, and the patient can, is not particularly bothered by that. Something that can be done also as conservative management is pelvic floor exercises, more commonly known as Kegel exercises. Very important to help your patient find the correct muscle to exercise. When performing Kegel exercises, I see that's probably the biggest mistake when patients do Kegel exercise. They don't work out the right muscle. Sometimes they're flexing their abdomen muscle, they're squeezing their buttock muscle, but that's not really going to help you. And they give you a six-pack, but may not help you very much with helping your incontinence. So for my female patients, to help identify the patients, I generally advise them to place 1 or 2 fingers into the vagina and then see if they can squeeze the vaginal muscle, the levator ani muscles, really around their finger. So that can really help teach them to activate that muscle. So, for the patients that really have difficulty even with those techniques, finding those muscles, you can try biofeedback, which is a special pressure transducer, or pelvic floor physical therapy. So which is, I think of as almost like super Kegel exercises to help them identify those muscles and work out those muscles appropriately. Something else that can be considered is incontinence pessaries. So pessaries is something that can be used for both prolapse as well as incontinence. So this is a ring pessary with an incontinence knob. So the ring part will help with the pelvic organ prolapse, versus this helps restore some of the support around the urethra. So that will sit right under urethra. So many women do find these to be uncomfortable. These are kind of rubber silicone devices that are made that stay in the vagina constantly. Doesn't work very well for sexually active women. In particular, a lot of women find it difficult to take out and insert these themselves. So oftentimes in women that do have severe pelvic organ prolapse, I use these in, they come into the office for these to be taken out and removed and to be cleaned as well. So, may be a good option for some patients, but may not be the best option for many patients as well. So skip that. So what are some of the surgical treatments for stress urinary incontinence? So it really involves both open and laparoscopic surgery. So we'll talk about some of the Birch copal suspensions as well as the MMK procedure. These are a little more historic in nature, and I'll talk to you about why. So the predominant treatment option is really urethral slings. So whether that's synthetic slings or fascial slings, these are the predominant treatments that are used these days for treatment of incontinence. Urethral bulking agents is another option, but their efficacies, they are less invasive, but tend to be to be less efficacious, significantly less efficacious than slings, as well as artificial sphincters. But they don't quite work very well in women. I'll talk about artificial urinary sphincters briefly at the end. But they're primarily used for male stress urinary incontinence rather than in women. So things to consider before taking a patient for surgery for stress urinary incontinence. And like I said before, you want to make sure that they really have stress predominant incontinence. You don't want to use it to treat the wrong type of incontinence. Have they tried conservative therapy? And is the patient an acceptable surgical candidate? So not everyone, is necessarily a surgical candidate. And does the patient desire future pregnancy? For instance, if you put a urethral sling in, if they have another pregnancy and vaginal delivery, that may significant, after, things may work hunky-dory all well after, in between onto the next pregnancy. But, after another vaginal delivery, that can disrupt the sling location, and they have a high chance of recurrent stress urinary incontinence. And what does the patient prefer? For instance, not everyone, there's been a lot of bad press around particular vaginal mesh. So, while mid-urethral slings, synthetic mid-urethral slings is a vaginal mesh, I would almost put that in a different category into some of the stuff you heard about vaginal mesh. A lot of the complications, the stuff that have been taken off the market revolves large vaginal mesh that are used for pelvic organ prolapse. Those are essentially no longer used. While you can get some similar complications with mid-urethral slings, it is a much lower risk procedure than transvaginal mesh for pelvic organ prolapse. But you have women that come in. I've heard all these bad things about mesh. I want to have a native tissue repair using my own tissue. So maybe mesh slings are not the best option for those patients. So let's talk about the different surgery options. So again, this is the Marshall-Marchetti Krantz procedure, where the periurethral tissue in the area around the urethra is kind of sutured to, and this came out in the 1940s, so it's a very old surgery, to the periosteum. So this is of the pubic bone. So this is a sagittal view. So you have the urethra and periurethral tissue here, and this is the pubic symphysis there. So you suture you attach to that periosteum. So this is again more of a historic surgery. Had okay efficacy, but one of the potential side effects, you can get an infection and inflammation and off that the pubic symphysis, and can have chronic pain there, be very difficult to deal with. So it's really not used anymore. And this was largely replaced 1961 called the Birch copal suspension, where the periurethral tissue, instead of attaching it to the periosteum of the pubic symphysis, it's attached to some of the lateral ligaments. It's the Cooper's ligament, on either side. So, for periurethral and copal, kind of urethral suspension surgery, this is kind of the gold standard these days. And still potentially an option, not used very often these days, but still a potential option for certain patients. So again, this is just an illustration. So, you take some of that periurethral, so this is the bladder, and you see a Foley catheter in there, and you take some sutures, these are absorbable sutures, and you attach it to that lateral, some risk getting infection and inflammation in the bone. You don't have that issue here. The efficacy is similar to the MMK procedure, and we'll compare this to some of the other slings in a little bit, but this is kind of the basic gist of this particular operation. So it does have good and medium term results, but longer term outcomes tend to be lower over time, which the Birch copal suspension. So let's talk about slings, and this is really kind of the mainstay these days for treatment of stress urinary incontinence. So you can use a tissue sling, whether that's taking your own tissue, and that's usually harvesting from the fascia, the abdominal fascia, or you can take them from the fascia lata from the thigh. So, it's a little more morbid, particularly on the harvest portion. There are some people that, I don't do this, but there are some surgeons that do use cadaveric tissue to make a fascial sling. Obviously, you remove the morbidity of having to harvest that tissue, but the long-term efficacy of this, the data I have seen, is really not quite the same as the autologous fascia. So I tend not to offer this to my patients. And then, what's really probably about over 90% of the sling and the stress urinary incontinence surgeries out there as a whole is the mid-urethral slings. And we'll talk about the different types of approaches you can do these synthetic mid-urethral slings, whether that's through a retropubic sling, where the sling goes behind the pubic symphysis, to the transobturator sling, where the sling goes into the transobturator foramen, and as well as single incision slings, where this is probably pretty similar to transobturator slings, but it doesn't quite come out all the way to the skin level. We'll go over some of these in a little more detail. So let's talk about autologous fascial slings. We talked about this a little bit. It could be harvested from the abdominal fascia, from the lower rectus sheath. So it's essentially very similar to a C-section incision from a fan and seal incision, where you need to make an incision about that big to harvest that. So it's compared to a mid-urethral sling where you have about a 2 centimeter vaginal incision and maybe kind of some pinhole incisions in the skin tissue where the sling comes out. This is a much morbid procedure, but it still has an important place. So I tend to harvest from the rectus sheath. There are other surgeons that do take fascia from the fascia lata from the outer thigh area as well. So this was first described in the 1930s, so quite a old operation, and became popular in the 1940s, and has a fairly good success rate, for about 2/3 to about 85% of patients have a good outcome with this particular surgery. So this is a description of more of the kind of what I tend to do from harvesting from the rectus sheath. So this is kind of a pelvic view. So you have the urethra, you have the pubic symphysis here, and this is kind of like that C-section, fan and seal incision where you cut down to the rectus fascia, and you harvest a strip of rectus fascia, and you pass that down to under the urethra. So this is the passing maneuver. Once that tissue's been harvested, you need to defat it. You attach some sutures to it and use a clamp to pass it down and then bring that back up. It's kind of actually similar to a retropubic sling of a mid-urethral sling, although I have to say that the anatomic location of these fascial slings is different. These are placed at more around the bladder neck, versus the mid-urethral slings, by definition or name, are placed at the level of the mid-urethra. And I tend to, one of the potential side effects of this surgery is these can be more obstructive, actually with any slings, but probably the highest risk with autologous, with fascial slings, is it can work too well, you end up with the opposite problem, and the patient can't empty their bladder at all. So, they may need a catheter. Usually with fascial slings, they tend to loosen up over time. So if the patient's unable to avoid afterwards, you leave a catheter in for a few weeks, they tend to be able to avoid, for most patients, afterwards. If not, you may need to go back and revise a sling. That's not the case for synthetic slings. If the patient's not able to avoid fairly quickly or the same day of surgery, if patient, for instance, in the recovery area is not able to avoid, I probably would rather go back that day and kind of loosen that sling a little bit. So you don't want to wait on a synthetic sling versus a fascial sling. These tend to loosen up over time a little bit. So, all right, so who are these slings ideal for? And I talked about patients that just don't want any type of vaginal mesh. Younger patients, I'm a little hesitant to be putting mesh slings into someone who's 40 years old, who may still have another 40, 50 years of life. And then the risk of mesh complications does go up over time. What are your risks of a mesh erosion over, say, a 70-year-old who may only have 10 years of life expectancy left versus a 40-year-old, 40 years? It's probably significantly higher over time. Patients with recurrent stress urinary incontinence, so you already previously had a mesh sling, you can consider putting another mesh sling in, but this may be a better option for some of those patients, or patients who had complications with mesh. So actually, the other day I just did a surgery in a patient who about 10 or 15 years ago had a Transobturator sling placed. And this is a fairly rare complication. The mesh completely eroded into around her proximal urethra and her bladder and neck, and was actually causing urinary obstruction. She was having difficulty emptying her bladder because the mesh was sitting in the middle of the urethra and blocking her from being able to urinate. So in that patient, I didn't do the stress urinary incontinence. So probably she's going to have recurrent stress urinary incontinence. We went in and removed the mesh and repaired the urethra and the bladder. And I would expect her, when she comes back, to have significant stress urinary incontinence. That's probably not a patient I'm going to want to put another mesh sling into. So a pubovaginal sling would probably be a good option for her. Patients with chronic pain, mesh can cause pelvic pain. This is a little lower risk. Patients prior radiation, where they may have higher risk for mesh surgery, as well as certain neurogenic patients, as well as patients that that the intermittent catheterization patients go along with that. Pubovaginal sling are probably better options in those patients as well. So how does this compare to the Birch copal suspension? So this is kind of one of the reasons why slings have kind of overtaken the Birch suspension when it's not used. So, looking at longer term outcomes, there's about a 2/3 success rate with the autologous pubovaginal sling versus about a 50%. So it did show this to be significantly better in success than the Birch suspension. Unfortunately, when this came out in the early mid 2000s, the mid-urethral sling were already coming to 2007 when that paper was published in NEJM, was already to be gaining in popularity. So I would say probably at this time in 2007, when people were getting slings, probably a decent amount were still the pubovaginal slings, a good portion. But I think, as I mentioned before, over 90% of sling surgeries these days are with the synthetic slings instead. So I think we'll skip that. So let's talk about the mid-urethral and the synthetic slings. So this is using a synthetic material. What is it? It's essentially a piece of plastic. Different manufacturers have different formulations of it, but it's polypropylene is what most of these are made of. And these are supposed to be put in tension-free. And we'll talk very briefly about male incontinence and how that treatment is different. So when you have the hypermobility, when the urethra, usually when you have that backing tissue, the urethra weakens and it doesn't have that backstop. And when you cough down, the urethra could travel and move quite a bit. And that's when you have that hypermobility and leakage. So, but if you put the sling, right under your urethra and provide that backing, when you cough and strain, it provides that backstop. So, and this has a very high efficacy rate, usually about in the 80 to 90% rate. So, generally this, at least similar, if not better than the pubovaginal sling. So, and this is a much less morbid, at least at the initial operation, a much less morbid and invasive operation versus the pubovaginal slings. Patients generally have to stay in the hospital versus this is probably, honestly, the operative procedure part, about 30 to 45 minutes, and patients, almost always can go home the same day. And it can be placed both, as I mentioned before, behind the pubic symphysis or through the transobturator foramen. And it can be kind of placed in the inside out or outside in. I'll explain a little more detail what that means when I have some pictures of these different procedures. So first, let's talk about the different positions of placing the sling. So here's the kind of skeletal anatomy with the bladder there. So the transobturator sling goes before this into the obturator foramen. You have the inferior pubic ramus there, so you want to use that as a landmark. And you want to keep it medial close to that because the obturator vessels and nerves are actually in that superior lateral portion. Obviously, you don't want to be hitting a nerve, vein, or something, run into kind of all sorts of issues there. So, this is the inferior pubic ramus is an important landmark for transobturator slings. Retropubic slings is placed underneath the pubic bone, so it kind of runs alongside. So just kind of both are, trying to accomplish the same thing, but they kind of travel in a little different direction to provide that additional backstop. So I would say, as a general rule, most urologists who do these surgeries tend to do more retropubic slings versus my urogynecology colleagues. The majority of them tend to prefer the transobturator sling. I think it's just a little specialty dependence. And we'll talk about some of the potential risks and complications of each, and that may elicit why that different specialties may prefer the other. So it's a polypropylene sling, first introduced as a TBT, the tension free. So that's something that's important. This is not you don't want to be cranking this up and then closing the urethra. It's not closing the urethra opening. It's just to sit underneath to provide that tension-free support. So that tension-free is a very important concept here. Again, the cure rates, it's up to 80 to 90%. And this is the TBT by, this is a J&J product, was really the first one that came out. And, and it has good long-term success rates as well. Potential complications is really bladder perforation. So this is one reason I think one of my gynecology colleagues, they're a little less comfortable. As urologists, if we put a hole in the bladder, actually, if you pass this into the bladder, you really just have to recognize it. So we always perform a cystoscopy at the time we perform this operation. You just have to recognize it at that time and then just repass it. I may leave a catheter in for a day or two, but it's at least such a small hole, really not a big deal. And these are extraperitoneal perforations of bladder. So you guys probably learned in medical school that intraperitoneal perforations of bladder, where you have urine leaking to the bladder, is a medical emergency, versus an extraperitoneal perforation is usually contained in the extraperitoneal space, if there's even any leakage from such a small perforation, and can be managed conservatively with a urinary catheter. So has long-term success over up to a 17-year period. At 17-year follow-up of the original TBT study, over 90% of the women were still having good responses at that time with the TBT. So again, like I mentioned, this is probably a little more detailed than what you guys need to know. This can be passed from the top down, or you can pass, identify the pubic symptoms and pass from what's called a top down approach versus bottom up. There's some evidence maybe the bottom up approach irritates the bladder a little less. I think you may be able to get the sling a little further away from the bladder versus the top down, but the data is not particularly clear. I think it's really more of a surgeon's preference issue. So let's talk about transobturator slings. So this doesn't, go near the bladder. So yeah, I'll never say never. You can still perforate a bladder with a trans if you really don't know what you're doing, and you kind of, you can. But the risk of perforating a bladder is much lower because of the direction it's going. Again, this could be passed inside out or outside in as well. And it was really developed to stay away. So sometimes if someone has aberrant anatomy, they had a prior operation, they may even have some of the potential risk of, although very rare, of retropubic slings, you can hit intestines, major vessels, versus with a transobturator sling, you don't really, run into, you're in generally a little safer area of working. So the potential risk of going through the intestines or something like that is lower with this. Although one of the potential risks of transobturator slings is, chronic pelvic pain, particularly if it goes through some muscles and the tendons here, it tends to go through more layers of that. So there is a higher risk of chronic pelvic pain with transobturator slings compared to retropubic slings. And I do both, but I would say the majority of the slings I do are retropubic slings. So again, there's a study, this is I believe the Thomas trial, again, published in New England Journal of Medicine, that compared transobturator to retropubic slings. The efficacy is pretty similar between the two. However, the real big difference is in the potential side effects. With retropubic slings, you may have a risk of perforating bladder at the time of the surgery, about a 5% rate with retropubic slings, about 0% with the transobturator slings. Again, if you recognize this at the time of surgery, you just repass it, really not a big deal. Where this really becomes a problem is if it's not recognized at the time of the surgery. And there's a higher rate of pelvic pain with the transobturator slings. Again, the long-term data probably shows that these two are similar, satisfaction rates are similar. There may be a little more de novo voiding dysfunction with the retropubic slings because they tend to be a little tighter. And I think, something that we mentioned earlier with the intrinsic sphincter deficiency is the retropubic slings, I think, tend to work a little better for the patients with ISD versus transobturator slings, because they, in terms of ranking how tight slings are, the pubovaginal slings are probably the tightest slings versus retropubics are the second, and the transobturator slings are probably the least obstructive of slings. There are also single incision slings. These are pretty similar to transobturator slings. The initial ones that came out weren't very good. The TBT Secure actually had very high failure rates, and this one is essentially off the market. I think that probably the best single incision sling out right now is the Altus Sling by Coloplast, and that does work actually fairly decently. And here's, I believe, the Altus data, and they showed about a similar efficacy compared to the transobturator and as well as the retropubic sling. So this is a potential option as well. So these use essentially a anchor that anchors these into the tissue in the transobturator foramen. It's almost like a, if you guys ever see those drywall anchors, it's kind of a one-way plastic drywall anchor that anchors so it can go in, but have a trouble being pulled out. So the one thing I'll say about these, they don't have the long-term data. As we saw in one of the earlier slides with TBT, there's 17-year data showing the duration efficacy. So with these, we don't quite know how long these will last, but this is a potential option as well for patients. So what about urethral bulking agents? This is there's all sorts of different formulations that are available, Durasphere, Macroplastic. I'll say generally the efficacy of these responding is about 50%. This is it's the least invasive, so you go in cystoscopically and you inject some of these agents to try to kind of cause some more better coaptation of the urethra. Response rate is about 50-60% with these. They don't tend to last as long as the slings. Where I tend to use these the most is more as a adjunctive therapy. For instance, when you did a sling on, maybe the sling wasn't the tightest sling, they're significantly better, but not 100% and go, this could be something I can consider. Or someone who really just wants to, willing to take a shot, if they're not, they don't want some, not that a sling I would put as a minor surgery, but this is even a smaller operation. They just don't want to deal with a sling for whatever reason. They want to try this first. And if they don't respond, you can still consider sling as a potential option. So this is just a Cochrane review comparing the urethral bulking agents and really pretty much some of the lower success rate. And a lot of the data didn't actually show a good efficacy for the bulking agent. So I don't use this too often, but just in select patients, but something for you guys to be aware of. So for about the majority of this presentation, we really focused on treating stress urinary incontinence and identifying stress urinary incontinence in women. So let's just talk briefly. I don't want to leave the men out, kind of give a little bit of love to all the male patients out as well. So again, this is a much rarer condition in men. So, the number I see most quoted often in women is about 1 in 3 women have, will develop stress urinary incontinence. But in men, this is particularly common after prostate surgery, especially radical prostatectomy for prostate cancer, patients that had prior radiation. So you can also do a sling in male patients, but this is kind of not, you have to consider this in selected patients. I would not do a sling in a patient that's been previously radiated. Having that constant tension there can really lead to higher risk of erosion. Even more so than in a female patient. In a female patient who had prior pelvic radiation, whether for uterine or cervical cancer, I would consider doing a sling if needed. They would have to understand there's potential higher risk of complications versus for a male patient who had prior radiation, I would simply not even offer that as an option. Partly because the male sling works a little different. So this sling actually, if you look at it, when you tension this sling under cystoscopy, you actually tension it onto the urethra to kind of close it up a little. So it's actually partly obstructive, the male sling versus, the tension-free concept in the female sling to provide the backstory. So this really works differently. And, for select patients that have mild stress urinary incontinence after prostate surgery and has not been previously radiated, and they're not looking to get radiation anytime soon. As well. So the mainstay for treating stress urinary incontinence in men is really what's called the artificial urinary sphincter. I told Dr. Hakim I won't have too many graphical images, but at least this is a cartoon and not a, but this is, so pretty much there's a control device that controls the cuff that surrounds the urethra, and it applies a constant pressure to the urethra and keeps it shut. So it kind of simulates your own external sphincter. And when you actually want to urinate, you actually squeeze this control device and it actually releases the pressure in that temporarily for about 60 seconds, allowing you to urinate. And slowly the pressure will return back in and closing that off again to maintain continence. And this has, again, a very high success rate, about a 90% success rate in patients, and works very well. Again, I do this mostly in men that's had prior radical prostate surgery. And you can do the artificial sphincter in both men and or in both men with both radiation and men with who have not had radiation previously. And the artificial sphincter, I will just very briefly mention, I mentioned already that it's really not used in women. The only setting in female patients where I would consider probably using this is maybe in some certain neurogenic patients that you really want to close off the bladder neck with certain neurogenic, spinal cord injuries, conditions, spina bifida, and you would place this at a different location. I would place this at the bladder neck. You have to use a fairly large cup. So very, very selective cases, this would be used in female patients. So just a quick summary. So they're minimally invasive. So, the biggest reason that the synthetic slings took off is that they're such a fairly minimally invasive surgery, literally just a 2-centimeter incision, about a 30-minute operation. And the patient's, leaking urine beforehand, they're walking out. About 90% of the patients, they're, essentially cured of their stress urinary incontinence. Again, about 80-90% success rates with that surgery. And it's, about the majority of stress urinary incontinence surgeries is with synthetic slings. But there's still an important role for both the Birch copal suspension as well as the autologous pubal vaginal slings in certain patients as well. So again, transobturator slings and retropubic slings have similar efficacy, but really it's based on surgeon's comfort as well as on different side effect profiles that, if patients are more concerned about the pain or chronic pain, maybe the transobturator sling is not the best option. But if they're concerned about, maybe injury to their bladder or potential irritative symptoms, someone has a lot of bad overactive bladder already, the retropubic sling is more likely to exacerbate that after. And, really urethral bulking agents used in selective settings were very mild incontinence, or as an adjunctive therapy to patients that already had a sling. Or perhaps if they did pelvic floor exercises, they got them 80% of the weight there, you can do a bulking agent to get them completely to go. So I think these are some of my references. And I'll leave my email up. If you guys have any questions, feel free to shoot me an email anytime, to reach out if you have any other questions regarding any urology issues or just any questions regarding, there's a wide range in the field. I'd be happy to answer any questions. So right now, I'll open it up to questions if we have any in our chat.
Thank you, Dr. Ji, for such an incredible presentation. I have no idea how you made such a complex procedure sound such an easy way of actually performing it. I know that the students are just flipping over it. So how interesting. I'm sure the group will have some questions, but if not, maybe we can talk about a few things. Please remember to the audience, please remember to post your questions in the Q&A feature in the bottom of your screen, right next to the chat feature. Type your question. You can do it in Spanish if you wish. I will do my best to translate that to English. But Dr. Ji, several things come to mind. I mean, what a wonderful approach to such a common problem. And it is somewhat mind-boggling to me that we're still talking about issues with the mesh. Although the technology has changed, we still see that there are complications that may ensue or arise in the future. And in your presentation, you mentioned that you have to make the distinction between the ages of the patients because of the obvious reason.
Yeah.
Now, at times, patients will say, well, why do I have to undergo the mesh when you have the other type of procedure like the sling that you mentioned, with the fascia? What is the push-pull for you when you have to make a decision aside from the age of the patient to use a mesh versus the fascia?
I think, we're talking, again, we had to kind of distinguish between transvaginal mesh for pelvic organ prolapse. Those meshes were literally a piece of mesh that big, and those were being put in essentially blindly, frankly, by a lot of surgeons when they came out that didn't really know what they were doing. That really led to a lot of the bad cases of pelvic organ mesh. Versus for these, really, we have a pretty good idea where these are much thinner strips of mesh. They're going to much certain areas that we have a pretty good idea where they're going. I would say the mesh sling is really the default option. I do offer a fairly patient-centric approach. I do describe all the potential, including bulking agents, even though I'm not the biggest fan of them. I do offer all of that to patients. And I would say for the majority of patients, as soon as you start describing the autologous fascial sling, that it's just a much bigger operation than the synthetic slings, that the majority of patients, even if they've had a little bit of hesitancy about pelvic organ mesh, tend to go with that option. So, but I do offer the pubovaginal slings to pretty much all my patients as well. So.
Great. There is a question from one of our guests, and it says, are you familiar with interstitial cystitis? What are the latest treatments that you recommend for these types of patients?
Oh boy, that's a bit of a loaded question. So interstitial cystitis, it is a very, it's a very difficult disease. It's not a very well defined disease. So it's almost a diagnosis of exclusion. So to the students out there that aren't familiar with it, so interstitial cystitis, also known as bladder pain syndrome, is really just painful, chronic pelvic pain, kind of falls into a similar kind of area of diseases, and it has a lot of overlap with overactive bladder in particular. So you see a lot of patients with overactivity, but really what defines interstitial cystitis, one, you have to rule out other causes of that infection, if they have a tumor that can cause similar symptoms. So it's a really diagnosis exclusion. But I would say for one of the key identifying factors for IC, or the abbreviation for interstitial cystitis, is patients that have bladder pain, but after they go to the bathroom, that pain is significant and improves. So that's really one of the telltale signs of IC. So IC is really not well understood. I think it's thought to be maybe an autoimmune disease and maybe a heterogeneous mix of different diseases. Sometimes you can see these Hunner's lesions or inflammatory lesions that if you see those, that you see in a minority of patients, but some of those patients you do find those in, you can go in and cystoscopically fulgurate, burn those lesions. That can cause improvement for some patients. So it's almost, there's hydrodistension. Sometimes patients will be under anesthesia and you just stretch out their bladder. That's another potential option. You can do bladder installations as well. So you fill the bladder with steroids, with heparin, different people have different mixes, and that could be helpful. It's there's different anti kind of inflammatories or immunosuppressants like cyclosporin can be tried as well. So it's almost, you had to cycle through different treatments, and different patients may have different methods that work for them. Obviously, the most basic before you try anything invasive is try to help patients identify bladder irritants like caffeine, spicy food. There's a whole list of stuff out there, and it's different for different patients. For patients, try to avoid those as well as you try conservative therapies. And then for really bad patients that really end stage IC that can really almost destroy the bladder, you can even consider cystectomy, although that's very, very rare. One thing I will mention, because on the student's question, is I do see a lot of overlap of interstitial cystitis and overactive bladder. So, this is a little bit off label for the use. So there's sacral nerve modulation. So this is a stimulator. So it's almost like a pacemaker for your bladder. So we have pacemakers for our heart. You have a pacemaker for your bladder. It's a wire that gets inserted into the S3 foramen. And we do this mostly for overactive bladder or urinary retention or fecal urgency. But there is some data out there, and I've seen it anecdotally, that I will only do it for my IC patients that also have overactive bladder. You put these in and it helps with overactive bladder, but you also see sometimes in some patients significant improvements in the sensory symptoms as well. So this could be a potential therapy for some IC patients. But again, the IC portion is off label, and there are some studies that are currently underway to see what's the efficacy in that setting.
Wow. Are the Kegel exercises helpful for men, for pathologies in men as well?
They are, in particular for the stress urinary incontinence, and again, much less common, for men that undergo radical prostatectomy or has stress incontinence after radiation therapy. I gave some instructions to my male patients to finding them, obviously they don't have, helping them identify the muscle is a little more difficult actually than in the female patients. So, it's, but that is helpful for men as well.
Okay, we have a question in regards to a 70-year-old patient who had prior mesh placement procedure, no longer can control his urine incontinence, and and they're wondering if it's still recommendable to go through a sling procedure.
So I will want to figure out why that patient is still leaking. Do they have recurrent stress urinary incontinence, or do they have overactivity? If they have overactivity, we got to treat the overactivity, whether that's through anticholinergics, beta-3 agonists, or I mentioned the sacral nerve modulation or Botox injection are good alternatives for treating the overactivity. If they do have recurrent stress urinary incontinence, I would talk to the patient seriously about whether they want to have another mesh, a sling procedure or not. And I would try to obtain the previous medical record to see if they had a prior transobturator sling or a retropubic sling. If they had a prior retropubic, and if they still want to have another mesh sling and they still just like don't want the pubovaginal sling because it's more morbid, if they had a prior retropubic sling, I would probably do a transobturator sling just because it comes in a little different direction and different angle. But if they had a prior transobturator sling, I would offer them a retropubic sling. Of course, I will offer these patients a pubovaginal sling. But the most important part is identifying whether they actually have recurrent stress incontinence with a overactivity aspect. And something I talked about earlier in the presentation is where I think urodynamics can have a really important role in this setting.
Right. And it is for overactivity.
Yeah.
So how long, what is the, how long can a sling be in place? Do you have to ever revise it?
Well, you only revise it if it's causing issues. So in theory, it's a permanent implant. So that's why, obviously with any of these implants, whether it's an artificial sphincter, a penile prosthesis, or a sling, the longer they're in place, the more likely they are to cause issues. So, in a young patient, I'll be a little hesitant to put in a mesh sling because it's going to be, can I be that confident this mesh is not going to cause issue, or the sphincter is going to last for 40 years, something like that? No, so I'd be a little, probably push them a little more towards using some type of native tissue kind of sling.
Right, and the same obviously goes with those that suffer from the pelvic pain after the sling implant.
Yeah.
Those definitely will qualify. Would you bring them back to OR to see?
Depending on, most of those pain, do resolve on their own with conservative
okay. So they eventually
therapy.
resolve.
If there's severe pain, obviously you need to kind of be a little more aggressive about it. I have seen pelvic pain after transobturator slings. Again, most of them can be managed conservatively, but in the ones that don't, you can consider a sling removal. So, but that again, and I've done a few of these. The removal surgery, I mentioned the sling surgery itself is a fairly minor surgery. The mesh removal surgery is a much more extensive and morbid procedure. So
It is.
we want to avoid that if possible. So you got to be judicious in who you operate on. So.
And that's what we have here, Dr.
Yeah.
Dr. G. I mean, we are just fascinated with all the techniques that you use. We can keep you for another hour if you allow us, but we need to be considerate to you and to all today's participants. We are at the top of the hour already. And on behalf of all in our team at International, thank you once again for that great presentation and for all of you for participating and for your questions. If you have additional questions for Dr. G, please send them to us at internationalbaptisthealth.net or call us at 786-596-2373. We'll look forward to seeing you again at our next quarterly medical lecture scheduled for Wednesday, May 19th of 2021. Please stay safe, use your mask, get vaccinated, and Godspeed to all. Thank you, Dr. G.
Thanks everyone for joining. Have a good afternoon.
You too. Thank you.